Okay. Welcome, everybody. Thank you for joining us this morning. We are going to talk to you about doulas and the doula program, the impact that doulas have on birth outcomes, how we can all work together to make sure that those outcomes are better than what they are now, and a few other things in between. And we'll have opportunities for questions and answers as well. So we're just gonna introduce ourselves. We are Earth's Natural Touch Birth Care and Beyond. We are doulas and perinatal health advocates who work to reduce the risk of undesirable pregnancy and birth outcomes, um, promote perinatal wellness for parents and children, and promote breastfeeding advocacy to all families, while also working to eliminate racial and ethnic disparities in infant and maternal health within undervalued and underrepresented communities. So I am Sayana Devotion. I am the founder of Earth's Natural Touch Birth Care and Beyond. I've been a doula since 2001, so this year is 20 years for me. I'm also a postpartum doula, childbirth educator, maternal child health specialist, certified lactation counselor. Currently, I'm a midwifery student, a bunch of things in between, but I'm also the doula trainer for Earth's Natural Touch Birth Care and Beyond. And you'll hear more about our training as we go on. Next, we have Dr. Lucinda Canty.
Okay. Hi, everyone. My name is Lucinda Canty. I am a nurse midwife. I am also an assistant professor of nursing at the University of St. Joseph, and I work per diem at Planned Parenthood. And I'm just an advocate for maternal health, and I'm a maternal health consultant with Earth's Natural Touch. And
Nice to meet you, Dr. Canty.
thank you. And next we have Cynthia.
Hello, hi. Can everyone hear me okay?
Yes.
I have in the background, terrific. All right, I am Cynthia Hayes, and I have been a doula for 17 years. I'm a certified doula with ENT for almost 3 years. I was part of the second graduating class. I'm also a certified lactation counselor, maternal and child health specialist. And I also have another life working for the state of Connecticut, almost 27 years. That's it.
That's us. And we'll be with you for a little while today. So you'll hear from each of us a little bit more. So our goal today is to join you in creating better birth outcomes by giving insight and historical context that'll become some of the tools that we can use to create collective change. So Black women and leadership are centered because it's been proven that when that happens, the entire community becomes healthy and whole. The remedy will be born out of engagement and collaborative efforts between doulas, medical professionals, and the community that we serve. So where did the concept of doulas come from? One of the most memorable events in a person's life is the birth of their child. And throughout history and across many cultures, there's a long history of women who specialized in supporting others during childbirth. Young women also grew up learning and seeing and interacting with their community midwives, and they learned the process of labor, birth, breastfeeding, and childcare. But now doulas are trained professionals. So they provide emotional, physical, informational, and even logistical support to parents during labor, delivery, and the postpartum period. But there are also doulas who focus on other aspects of reproduction, such as fertility and adoption and bereavement. And sometimes you'll hear them called birth sister or birth keeper or birth coach, birth companion, but we use the term doula. So what do doulas do? Professional birth doulas providing continuous labor support use complex emotional support skills that are different than what obstetric nurses use or midwives, which might explain the positive obstetric and neonatal birth outcomes that are seen while doulas are present at births. Studies show that the best birth outcomes are seen when a person's continuous birth support person is not a family member, not part of their social network, and not a hospital employee. Doulas work for the families and not for their providers. Doulas are also those extra eyes, ears, and hands. They can be responsive to things and bring awareness to things that are outside the range of normal that might require a little bit of extra care. Doulas also work to make sure that the family is well adjusted, the parent's perinatal mood is good, and that the mother and baby are eating and recovering well together, with nothing alarming happening. Doulas can also help to reinforce positive parenting skills and care strategies for everyone. So as you can see on the right, there's a picture of a chart, and it's basically showing you the time of maternal death and when things typically happen. And a little more than half of maternal deaths happen during the postpartum period. And I don't think people really realize that this, considered to be maternal mortality up to 365 days or 1 year. So that person who has just given birth still needs some extra support, even in the postpartum. It's not just about the pregnancy and the actual day of the birth. And on the left, you see a picture of us in one of our classes preparing some postpartum foods. We do like a chopped, the doula edition, with random ingredients to make sure that we're able to provide families with nutritious meals, no matter what it is that they have in their homes. We can pull something together to make sure that they're good, or, even advise them on things that they can create themselves. Fertility doulas support people who are interested in conceiving that may be having challenges. And bereavement doulas provide physical, emotional, and informational support to families experiencing pregnancy loss, possibly one of the most difficult times in their lives. These parents are often still require physical support and will need to recover from their physical loss and also the mental strain. And we do come across a lot of families who have had previously experienced some losses or even some grief due to having babies in the NICU. Professional doulas are non-medical support persons who may have formal training from professional organizations. Some may even have nursing or midwifery education and experience or aspire to do so. However, many have not had any healthcare training at all. Currently, although doulas are generally unregulated, meaning that there are no legalized national standards, there are close to 90 known doula training organizations across the United States, and they each have their own unique personalities and specialties, with most having core competency commonalities. So traditional doula trainings are about 2 to 3 days on average. The Earth's Natural Touch Birth Care and Beyond interdisciplinary doula training is 14 months long. Why is ours so long compared to the others? Our training is 14 months because we know that after just 3 to 4 days of training, it can be very challenging to navigate all of the complexities that often come with supporting families in undervalued and underrepresented communities who are living with the weight of historical and generational traumas while navigating institutional racism and all of the social determinants of health, which can all influence their reproductive choices, options, and outcomes. Our program encompasses a wide range of knowledge from conception through to birth to postpartum, and many things in between, such as nutrition, grief and loss, toxic relationships, birth justice, trauma, breastfeeding, and so much more. And we carry those out through different training units over the 14 months. Overall, our training prepares doulas to support families in many environments and through a wide range of circumstances, encompassing the full spectrum standard, which is fertility, birth, postpartum, loss and bereavement, and beyond, making them Earth's Natural Touch Birth Care and Beyond interdisciplinary doulas. And all of the doulas who are going to be participants in this program are trained through our 14-month program. Community doula models often connect families with resources that could help them with their needs, such as navigating housing issues, food insecurity, clothing assistance, transportation, etc., which can all help to reduce the social stressors that the birthing person may be experiencing due to their race, sex, or socioeconomic status. These issues disproportionately impact low-income African Americans. Doulas can help them because many times African Americans face discrimination and they feel disempowered within the complex healthcare systems, and they help them to navigate the system and even help mediate the effects of institutional biases within healthcare systems. Many community doulas actually chose to become doulas specifically to take on the role of providing culturally competent support to birthing people. And here we are in one of our classes again. So why is this happening? As you can see from the chart, and you may have seen this before, since the 90s, the US maternal mortality rates are increasing while other countries are going down. So you can see Norway, Germany, Spain, Italy, Europe, their maternal mortality rates are declining while ours are increasing. But we spend so much money on healthcare, and we're performing worse than over 50 other countries. So we're just going to ask a quick question. I don't know how many people are on right now, but according to the CDC, how many pregnancy-related deaths do you believe occur in the United States each year? 400, 500, 600, or 700? And then what percentage of those do you believe are preventable? 10%, 40%, 60%, or 95%? I'll just give a few more seconds to see if anybody else chimes in. Okay. Can you all see the results?
Mhm.
So most people said 600 deaths in the United States per year, and most people said 95% of them can be prevented. So let's see what the CDC says. According to the CDC, there are 700 pregnancy-related deaths annually in the United States, and 60% of those are preventable. That's 420 mothers who die unnecessarily. We're not incompetent, and we know when something is wrong. What do many of the high-profile Black maternal morbidities and mortalities have in common? So when we look at these beautiful people on the screen, we see a number of people that represent this issue happening across socioeconomic classes, educational status, and relationship status, as evidenced by the pregnancy-related deaths of pediatric chief resident Shanice Wallace, just a few weeks ago, actually. She's down in the bottom left. And next to her, we have Shalon Irving, an epidemiologist at the CDC. We have Shamani Gibson, Sha'asia Washington, Amber Isaac, LaShonda Hazard, Kira Johnson, a woman named Jasmine, whose pain was ignored and assumed to be drug seeking. And the list goes on and on and on. And the common trend here was that they were all Black, but they were all ignored. Up in the upper left corner, you have Serena Williams. And we know that Serena Williams didn't die, but she had a horrible birth experience. And fortunately, she was able to advocate for herself to save her own life while experiencing a pulmonary embolism after giving birth, because she too was being ignored. So we just want to talk about the fathers. And actually, let me go back here. So the upper right-hand corner, you may have seen this family before. This is Charles Johnson and his wife, Kira. And Charles is the son of Judge Hatchett. Kira, his wife, died after giving birth to their second son. And he since then has become a big advocate and just very outspoken about making change in order to prevent this from happening to anyone else. And you'll see a video from one of the fathers who lost their son's mothers a little bit later. But our point is that, you know, this is not just about the women and their issues. This is about the entire family, including their partners and the children that they leave behind. The fathers are now responsible for taking care of those children alone. So when you send dad away, we just want you to kind of keep in mind that fear, tension, pain cycle, and how having a man present can often help us to feel supported. And we know that there are times where you have to ask specific questions when no one's around, but to try to incorporate that father into the situation can actually help to benefit the entire family. And so we are going to watch this quick video.
This was racial malpractice that took Amber. We lost someone very, very, very important to us. Amber was the light to everyone's life. Her energy was just amazing. She was just so loving, so caring.
During the height of the COVID-19 pandemic, Amber Isaac lost her life while giving birth to her son.
You're ready for a bottle. The fact that she never got to meet him really tears me apart.
Bruce McIntyre says his partner faced neglect at the Montefiore Medical Center in the Bronx.
This would not have happened if Amber was white. If Amber was white, she would still be here today. She would still be here.
According to McIntyre, red flags started to appear during Isaac's second trimester when she couldn't get an in-person appointment due to the pandemic.
In March, she was just getting like Zoom conferences, telehealth. They gave her a blood pressure monitor. She wasn't being seen that whole month. Amber's calling, reaching out, hey, I need the results back from the blood work. You know, the baby's due date is close. Nobody's reaching back out to us.
When Isaac received her test results, she learned that her platelet levels were dangerously low and was rushed to the hospital for an emergency C-section. Doctors learned Isaac had HELLP syndrome, a serious condition that affects the blood and liver. Days before going to the hospital, Isaac sent her final tweet, "Can't wait to write a tell-all about my experience during my last 2 trimesters dealing with incompetent doctors at Montefiore."
I said my goodbyes to Amber. I couldn't hug her, couldn't kiss her. I just had to try to talk her through it because she was scared, she was nervous. That was the last time I saw her. The last thing she had me doing was talking and singing to her stomach. That's what I did every night.
At age 26, Amber Isaac died during the C-section with no family members around her.
Amber Rose Isaac, such a sad story because of all the things that we know could go wrong did. She advocated for herself and she still lost her life. These fractures in our healthcare system, this dismissing of Black women, of women in general, is causing death. Their symptoms not being listened to, being turned away, not being evaluated, not being taken seriously. Those small choices can be deadly for Black birthing people.
According to the CDC, Black women are about 3 times more likely to die of pregnancy-related causes than white women. About 60% of pregnancy-related deaths are preventable.
Really, our entire healthcare system has to be revamped so that we make sure that people like Amber Rose Isaac are seen and valued, especially as we move to more telemedicine and not in-person health, because that's here to stay. We need to ensure that we look at Amber Rose Isaac's case as an opportunity of learning of what we really need to do differently.
In a statement, the Montefiore Medical Center said 94% of our deliveries are minority mothers, and Montefiore's maternal mortality rate of 0.01% is lower than both New York City and national averages. Any maternal death is a tragedy.
I used to sing to him and everything, play the piano for him and Amber while he was in her womb, and he always heard music, right? Yeah, he always heard music.
In honor of Isaac, McIntyre started the Save a Rose Foundation to raise awareness about the racial inequality Black women face during pregnancy.
Amber was very big on her community. With Save a Rose, I want to do like a lot of community engagement. I'm working with Birth from the Earth. Right now, we just put together a scholarship program that offsets the costs of insurance premiums. So whatever insurance doesn't cover, this program covers, and that's in Amber's honor. We have to lead by example. We have to fight for what's right. So that's all of the morals that I want Elias growing up with. Want him to carry that out throughout his lifetime. Everything that we're doing, I want him to be able to continue. Be happy. This was
So the video talked about fractures in the healthcare system, and we really want to work to mend those cracks by working together with you all. Did anybody have any questions or anything so far? because we're going to move on into the presentation.
No.
Okay.
We'll have time for questions at the end also. But one thing that we have to realize is race is not a risk factor, but racism is. And it's so painful for us to think about and talk about, but we have a long history of that in the United States. And for Black women, they never had control over their bodies. So we have a long history of poor maternal health outcomes. The saddest thing is that we did better pre-civil rights than we are doing now. Post-slavery, we didn't have a lot of resources, we didn't have any rights, and we're doing better. We did better then than we're doing now. And it's so important just to think about our history. And because of time, I'm not going to go deep into this, but this is from the book, Medical Bondage. So if you didn't read this book, it's such an important piece, especially if you're going to be practicing gynecology, women's health, maternity. This is something that you need to read and understand. And I always hear people say, well, I wasn't living back then. Why do we have to go back then? But I want to show you how what happened in the past still has an impact on us in this current time. And one of the things was looking at, Dr. Marion Sims. I'm hoping that you all are familiar with him, and Dr. Francois Provost. They were both doctors that practiced on slaves, that practiced gynecological surgery, that practiced cesareans. They perfected their techniques on slave women, and they often did this without any pain medication. And, and it just brings us to today, and again, at that time, Black women were not even looked at as being human, that we couldn't understand pain. We didn't feel pain. We were animals, and it's unfortunate. And this is from their own writings. So this is not something that someone interpreted. These are from their memoirs, their medical journals. So this information was out at the time. So now coming to present day, how does that impact us still? And this is just some questions I just want you to think about. What have you learned about how cultural groups express pain? How do you assess your patients, when you're looking at pain at their pain management? How do you determine who's at risk for opioid addiction? And how does your beliefs impact how you treat pain? These are all important questions that I want you to think about as you're practicing, because some of those old beliefs creep into today. Even though sometimes we don't even talk about it, we do know that women aren't believed. Black women are not believed when they describe their pain. There's still this misconception that we don't understand our bodies, and we're exaggerating our pain if we say we have pain, and it's because we're drug seeking. And there are 2 studies that highlighted how white women were more likely to be assessed for pain, especially after a cesarean, than compared to Black and Hispanic women. But Black and Hispanic women reported higher levels of pain when they were asked, but they were less medicated. And even discharged home after cesarean were not given, they were less likely to get an opioid prescription. So this is still currently happening. So those beliefs about how way back in slavery, we're still putting those on our patients today. So we do have to think about that. And we often look at how do, what's going on? How come, people don't trust us when they come in? How come they're not getting their COVID vaccine? And we know experimentation has a big part of that. A lot of experiments that were done without our consent. Henrietta Lacks was something that was about a woman who had abnormal cervical cancer cells. And they took her cells and used them to this day. They're still alive for experimentation, but it was done without her consent. We all know about Tuskegee, but the other part of Tuskegee, we heard of men that had syphilis that weren't treated, but these men went home to their wives who were pregnant and had children. And, we look back at our history and how there's that distrust. But the other thing that's still happening now is when women of color enter the healthcare system, I should say people of color, is how we're treated. And that contributes to our not trusting. And just imagine that someone's pregnant, they have a lot going on, and then they're worried whether or not their healthcare provider is going to be there and give them the care that they deserve. So mistrust is still a big issue that we have. A lot of it is based on what happened in the past, but also our own history when we enter the healthcare system. And we have to think about, what does all of this have on us as women, particularly Black women? And there's a term called weathering, is when there's chronic stress that, we just say, oh, that's just stress. Let her deep breathe, let her do this and that. But when you experience it every day, like experience racism every day, I can tell you as a Black woman, I mind my business, I walk into racism. I go in a store, I'm treated a certain way. I go to my appointments, I'm treated a certain way. It's like we can't avoid it. We can't hide from it. But it's what does it do to our bodies? And we're finding not only does it have that medical, harm that it's causing us, medical and physical harm, is also impacting our children that we have. So it's aging us in a way that's not healthy, that we're seeing more diabetes, more hypertension, just more overall poor coping because of these experiences that we have. And then we go into a system where people don't want to recognize it, and then you hear these things like even with Megan right now, who's talking about how she's almost being perceived as an angry Black woman. Even when you're quiet, you're the angry Black woman because you're too quiet. So you must be mad. Then you speak up, then you're angry and you're taking things where they don't need to go. But then you have people who don't want to listen to what you're saying. Then you're dealing with issues that may happen with your partner, with relationships. There's so many things that built up. And I bring this up because as healthcare providers, as women, as people working with women who are pregnant, we have to keep this in mind. And one of the saddest things, and this came through my own research of talking to women who almost died, I had severe complications, is they said that they found their healthcare providers were an additional source of stress. Either they were supportive or they were the stress. That either they went to them and they felt safe or they left feeling traumatized. So as healthcare providers, we have a lot of power in this. So we have to think about how that impacts the women that we care for. And what most women say is that they didn't know about certain complications or they don't know about how to care for themselves. That they feel like the healthcare provider assumes, and this is what a patient told me, that, oh, they just want to talk about WIC and food stamps and how I could get over on these government programs, but no one's telling me about the complications that can happen to me. So we just have to think about how we educate women. And when we say culturally appropriate care, it's not just about learning how this is what they eat, this is what they dress. I take my maternity textbooks when I teach students and pages that say, if they're Native American, this is what they do. I take those pages and I tear them up because that's not culturally appropriate care. Culturally appropriate care is learning where your patients are coming from and who they are, but still looking at them on an individual level. So we have to do better at that. But we have to realize that relationship is so important. And patients are watching you. And they'll often say, oh, they don't even realize how they're acting towards me. They don't even realize they're talking down on me. I'm a grown woman. I'm the same age as them. And they're talking down on me. Or I tell them this is going on and they're not listening. So patients see that. The women that you care for see that, but they feel like you just don't care. But women who do find that their providers get to know who they are tend to have a more positive experience. And that's what we want. We want them to have a positive experience and trust who's caring for them. And just the last piece is that mental health. Women are saying that they don't feel like anyone's even checking in to say, hi, how are you? How was your day? What's going on? And if they do have something an abnormal lab result, they have a complication during their childbirth or postpartum, just to have someone say, how are you? How are you feeling about this? Let's talk about it. Maybe you don't have questions now, but if you have questions later, we can do this. If this is making you feel a certain kind of way, we can get you the right support. Women are saying that they're not receiving that. And doulas can really help to bridge all of these things together and work with healthcare providers so that the women receive what they need. So they can, again, know those resources, know the type of stress, just be aware. For example, when George Floyd, when we saw that murder on television, it was like, for a lot of people, it was like, we're just moving on, business as usual. No one realized the impact that had on Black people, that had on me. When I watched, I was traumatized. But no one said, Lucinda, this just happened. We got to talk about it. Or even just recognize, this is to happen. So let me make sure I give her a little more attention and TLC because I know this is hard for her. it's like that's being ignored. But when you have someone who knows and understands that, then they're able to provide the right support and the right resources, therefore decreasing that stress. And overall, again, that stress can contribute to low birth weight and prematurity. So if we can give them that support, research has shown that doulas can lower those rates. Again, and have a better impact on those newborn outcomes. And just last thing that I want to touch on is just the importance of preventing that first cesarean. And we know that cesarean sections are needed. We know there are cases when it's important for the mother's lives or for the fetus life. But we also know that a lot of them are done unnecessarily. We have to be realistic about that. Sometimes it's done because of time. Sometimes it's done because I'm so worried as this baby's delivered, I don't have to worry anymore. But what we have to realize is that Black women are more likely to have a primary cesarean, which usually means any subsequent pregnancy will have to be a cesarean. Even though we say that next one could be a VBAC, we know that that's not often the case. But the other part of that is that these women have more severe complications, postpartum hemorrhage that requires blood transfusions or even hysterectomy. I interviewed a woman 21 years old and had her first and only child. They couldn't stop the bleeding. And she had her cesarean because she stopped at 6 centimeters. And they just said, you know, we could go another 24, 48 hours, or we could take the baby now. And she was like, well, let's just have the baby now. And the end result was they couldn't control the bleeding at her incision. They had to do a hysterectomy. 21 years old. And, you know, later we could talk about informed consent, because we all know there's informed consent and there's true informed consent. And if she knew her other options, she may have went a different path, but she says, I'll never know. But anyways, again, the complications are more severe. So if we could just try to prevent through, again, and doulas have been shown to decrease cesarean rates because of the support that they offer during childbirth and also the education that they provide during the pregnancy. So again, I want you just to keep that in mind. Okay, and so now I'll turn it over to Cynthia.
Thank you, Lucinda. That's fine. And so this next section is just going to be a reiteration of everything that we've just talked about. We're just going to drill down just a little bit more under the surface. When we're talking about ACEs, right? There are 3 types of ACEs that we're concentrating on right now, and that's abuse, neglect, household dysfunction. Now we know that ACEs, or adverse childhood experiences, is going to increase the risks of pregnancy loss and preterm birth. Now, although there's been studies about other types of health conditions and how ACEs affects that, there's not been enough studies on how this can affect a person giving birth. But now we have local task force, and I've had the pleasure of being invited to attend, and that's where I saw Dr. Golar at one of the local meetings that we had. And we're hoping that because we are invited to the conversation, and doulas are invited to the conversation, that we can look forward to doing more work in this area. And so again, just it's the emotional distress during our childhood years that can increase the risk of developing heart disease and metabolic disorders in adulthood, even in the absence of high stress during adulthood. This is how impactful these childhood experiences can be. All right, next slide. We have some charts. The first 2 I'm going to show you is specific to what's happening in Connecticut as of 2017. And I believe that these charts that I received are actually from the March of Dimes. I'm not sure, but there is a link, and we'll be sending references also later with the medical toolkit. But this is just showing infant mortality, okay? And of course, we see non-Hispanic Black women leading the pack concerning Black babies that are more likely to die before their first birthday than babies born to white women. Next slide. Also concerning, this is just Connecticut in 2018, Black babies are twice as likely as white babies to be born weighing less than 5.5 1.5 pounds, which can put them at higher risk for serious health and developmental consequences. Next slide. Now, this one is just talking about the national average, which, and we've seen in the previous video, is 3%, but we do know that in Connecticut, it is higher than the average, and it seems to keep rising. It was 4%, and then it was almost 5% when last we looked. Next slide. So the social determinants of health. And as some of us are aware, it's the conditions and places where people live, learn, work, and play, and it affects a wide range of health risks and outcomes. And so there are some of those that we have displayed there: the social support networks, education, employment, working conditions, all of these things, social environment, and the list goes on to talk about gender, culture, income, and social status. What we just wanted to point out concerning the social determinants of health is like the intersection and how it affects Black women and especially Black families. For example, any policies and income are drastically affected, or rather I should say income and where we live and how we live is drastically affected by certain policies. And that's inescapable for most of us, right? It's almost like a caste system. It's worse than a class system when it appears that Black people continue to remain at the bottom. And of course, it's going to affect our health as well. The next slide. The mother blame narrative. So the mother blame narrative refers to medical professionals putting complete blame on the caring mother or person for the outcome of their child's health. This narrative is dangerous for many reasons, starting with the fact that it takes the onus off of the medical system and puts it in the hands of the pregnant person. It also disregards the conditions that a pregnant person can be exposed to that is completely out of their hands. Like we just were referring to social determinants. There are some people that are born in certain conditions and there's very little help or assistance to remove them completely from that system, yes, because of the inequities. That includes living, working conditions, social economic status, education, and access to healthcare, housing conditions, community care. Being Black is already a factor that impacts that outcome. Exclusively addressing individual behaviors as the basis for health outcomes without a structural perspective can lead to stigmatization, scapegoating, heightened surveillance, and criminalization, all of which disregard the bodily autonomy of pregnant women, which we've already pointed out. Next slide. Cultural competence versus cultural humility. And I know that Lucinda was pointing this out. And there's a picture of one of my favorite historians, and it's Dr. Carter G. Woodson. And he is very famous for promoting the importance of cultural competence and cultural humility. And we need to talk a little bit about the slight difference between both. Yes, it is very important to be culturally competent, which is the ability to understand, communicate with, and effectively interact with people across cultures. The goal of medical professionals should be to effectively and in context treat and counsel with their patients from diverse cultures and backgrounds. So while it is very good to understand the significance that might appear regarding any of your patients' cultural background, it is more important to use cultural humility, which is learning from someone based on the information that they provide. This is based on questions you ask patients and their community to learn more about them individually, about what they need without making any assumptions. The next slide. And so we chose to take a look at Kleinman's explanatory model. Now, this is one that since I've learned about it, I've even adopted it. Many clinicians and therapists and other professionals in other disciplines use this. And this is a model that was created by Arthur Kleinman. Some of you might be aware, he's a psychiatrist and an anthropologist. And he created this model to help resolve communication problems and helping the medical professional get more of an insight regarding their patient when trying to resolve a medical issue. Using the explanatory model can assist with better understanding about the patient. In order to gain a better understanding, you have to ask some of those important questions: the what, the why, the how, and the who. And generally, I've noticed that there have been at least 8 questions that should be asked when you first are discovering that there is a medical issue and when interacting with the patient. And the whole premise is stating that the patient has a model regarding their care based on prior experiences. Maybe there's something that they've been trying that is cultural and it probably needs to be tweaked a little bit. They were like, well, I have some herbs and some other things that can cure this. It's like, talk to them about that. So when the medical provider is asking certain questions, that's how you can learn about what they feel about their certain condition. When do they think that it started? Why do they think that it started? Why do they think that they're having a certain problem? It's getting into the heart of what the matter is. And by that way, now the medical professional and the patient can come together so that they can create a model that works for everybody. And I just had one question at the bottom, just for you to consider: how can the application of this model, if you're not using it or others like it, help create better birth outcomes for the Black and Latinx mothers living in Bridgeport? Just something to consider. The next slide. Structural competency. So structural and or institutional racism, which is what we've been talking about by and large, is the normalization and legitimization of an array of dynamics which are historical, cultural, institutional, and interpersonal that routinely advantage whites while producing cumulative and chronic adverse outcomes for Black people. And I like that definition. It gets right to the heart of it. I lifted it from Dr. Tricia Rose, who's the director of Center for the Study of Slavery and Justice at Brown University. And we also see that the American Academy of Family Physicians recognize that racism is a system that categorizes people based on race, color, ethnicity, and culture to differentially allocate societal goods and resources in a way that unfairly disadvantages some, while without merit, rewards others. So when we're talking about structural competency, and the reason why it could be so important, when physicians and scholars seek to address the challenges and encourage healthcare professionals to recognize, analyze, and intervene upon the structural factors that impact health disparities, you have to realize that they are there first, and they are huge impediments to your patient getting well and receiving equal care. Cultural competency might still lend itself to stereotypes based on perception of culture, class, or race. So it's not enough to just say, well, okay, this is and a lot of us aren't even aware that, and it's not just one group of people, right? It's a lot of us that are interacting, especially with Black people. We're thinking, okay, this is a Black woman and she didn't get to her appointment on time. Maybe it's just not important to her, when really she had to do 5 or 10 other things and navigate a whole completely different system just to try to get to her appointment on time. And yes, when she gets to you, she might seem aloof, she might seem as if she doesn't care, but it's not that. There are other factors that are impacting her health. Next slide. Talking about breastfeeding. Why aren't more Black women breastfeeding? Some research shows that racial disparities in breastfeeding exist because of many reasons. Here are just some. African American women often return to work sooner than their white counterparts because they absolutely have to. And their workplaces are more likely not supporting breastfeeding. Hospitals and other healthcare settings often provide formula to healthy, full-term babies during the postpartum period, which decreases the likelihood of exclusively breastfeeding. She may have been separated from the baby during her hospital stay. She may not have the proper knowledge about the benefits and the risks of not breastfeeding. She is less likely to have seen it done successfully in her community and seeing it modeled, making her believe that it is an inconvenient to her lifestyle. She may believe that a big baby is an indication of a healthy baby, therefore introducing formula earlier than recommended. But those of us that breastfed have known, even exclusively breastfeeding, you get that big, fat, chubby, round baby. So we know that that's not true. She may believe that a big baby, I already said that. She may have been taught by members of her own community that adding cereal to a formula bottle will help the baby sleep through the night because she's concerned that she's not getting enough rest, especially if it's the pressure of having to get back to work, sooner rather than later. She doesn't want to have to worry about her baby waking up or waking her up even to be fed. She wants to make sure, and she's thinking in her mind that this is a healthier substitute. She may be afraid of being judged by a non-supportive community. In the next slide, it's an interesting slide. We all know Rudy, Keisha Pulliam, right? And she tells about her experience when she wanted to breastfeed. There's just certain assumptions that maybe she doesn't want to know and maybe she's not being asked because typically they're not going to do that, making the assumption that she's on WIC. She's going to give up anyway, the lack of hands-on lactation support. There have been some women who have said that there have been other white breastfeeding clinicians or counselors that don't even really want to touch Black women after they've had their baby. Just saying all types of things like your milk hasn't come in, here, take the formula, always saying, well, this is easier. And at the same time saying, well, because she's not going to want to really go through the trouble of breastfeeding anyway. So these are some of the very dangerous tropes and assumptions that they're making about Black women. And we have found, and we'll talk a little bit later about our lactation group, that there are some mothers who have stated that because they have the support that they need, they went on to breastfeed and breastfeed exclusively when they didn't even think. They were having problems with latching maybe 2 weeks after being pregnant. And we've been able to help them. And you could just tell that they were just like beaming and so happy and so proud, realizing that their body is made to do this. To take care of their baby. And we enjoy our Saturday mornings with those moms. Next slide. Taking a little hard left turn here. This is brief, probably too brief, but we're running out of time. Talking about PMADs and talking a little bit about perinatal mood and anxiety disorders. Depression that occurs during pregnancy or within a year after delivery is called perinatal depression. And that can be due to hormone changes and other possible triggers, other stressful life events, like being pregnant, like having a baby, and other things that can cause chemical changes in the brain that lead to depression. And I know as medical professionals, we're aware, but what we may not realize is that the occurrence of PMADs can affect 15 to 20% of new moms. And so, and there's a whole scale. On the lower scale, it may not be very unusual for a mom to be feeling sad, but if she starts to feel hopeless, overwhelmed, she has difficulty concentrating, she has sleeping problems, feeling restless or irritable, crying a lot. There's anxiety, loss of interest or pleasure in activities that she used to enjoy and just feeling like she has no energy, no motivation, change in eating habits, weight loss or significant weight gain, feelings of guilt or worthlessness. Postpartum psychosis, we know any psychosis is more severe problem, and that can lead to suicidal thoughts of harming the baby, and it could include visual or auditory hallucinations. And at that point, mom would probably need to be hospitalized. But at Earth's Natural Touch, we're made familiar with the Edinburgh scale, and we kind of work it into, when we're visiting mom postpartum, we work it into our conversations without her realizing that we have like a little checklist, just talking to mom, just seeing where she is and how she is. And, sadly, just not having enough support. They're all at risk, and having problems even with breastfeeding can often lead to problems with concerning PMADs. And I just offered the PSI warm line. We do a lot of work with PSI. Anyone can call if they're just feeling like they need to connect with a group specifically for parents that are suffering with perinatal mood and anxiety disorders. Next. So for everything that we've talked about, we know that doulas impact birth outcomes positively. There is shorter labor length, there's decreased use of oxytocin and augmentation drugs, less vacuum and forceps use, higher APGAR scores, increased near universal breastfeeding initiation, early onset of lactogenesis, increased breastfeeding length, lower rates of cesarean section, lower incidence of low birth weight and preterm birth, less pain and anxiety, less use of pain medications such as epidurals, and increased birth experience satisfaction overall. And these can all result in a huge reduction in medical costs just by having a doula. Next, please. So, and what we wanted to say regarding racial discrimination and adverse outcomes, as the United States becomes more culturally diverse, healthcare professionals are well positioned to educate themselves, their colleagues, and their students about the tenets of culturally sensitive healthcare. Eliminating racial disparities in birth outcomes necessitates a thoughtful commitment from healthcare professionals, policymakers. Hopefully we'll see a lot more changes in Connecticut as we speak. We're working on that. Social and economic institutions to eradicate racism and the ensuing social inequities. So when we talk about barriers to doula access, we're talking about lack of information about doula services. We're talking about the lack of available services. There's insufficient number of doulas that are Black or doulas of color. Most are able to do this work because they're white, they're more middle class, they're married, they have a support system. A lot of our doulas have to work a couple of jobs because they have families of their own, and they're just not in the social economic space to be able to provide these services on a volunteer basis. Although our doulas have been very dedicated, they do a lot of work that's voluntary, but we want to make sure that they're paid for their expertise. They work so hard. When we talk about the cost of the services, that is very prohibitive for Black families, which is why we're so grateful to have this opportunity and to work with Optimus, making it more accessible, because most insurance does not cover it. And many Black doulas and those that are from disadvantaged groups, like, as I mentioned before, are working several jobs. So they can't always afford to just do it on a volunteer basis. And also when we're talking about the acceptance of services, many medical providers are very unclear about a doula's role. And that's why we're, again, so grateful for this opportunity to be able to talk more about that, to make you more aware. Next slide. Why break barriers? So African Americans often report receiving worse interpersonal health care than their white counterparts, as we was previously stated. There's also a huge trust issue based on historical trauma and mistreatment within the medical system. Doulas, and specifically community doulas, who are among those populations and who have racial, cultural, and experiential similarities to the birthing person, can help to build trust with the parent and are in the position to be able to see and prevent overt effects of institutional racism, classism, institutional bias within the healthcare system, and then to mitigate many of the negative effects of social determinants of health that would normally impact the health of the birthing person and their children. We provide culturally, we provide culturally relevant care and having racial concordance between vulnerable families and doulas, and it can enhance the benefits that are already associated with doula support. This is why we need to break these barriers. So doulas can be further integrated into comprehensive systems of support, along with medical providers, to influence mothers' health choices and in order to improve birth outcomes. But not many providers recommend doulas, even though the benefits to patients, and it remains unclear. Doulas see themselves as part of the family's birth team and want parents to have great birth outcomes too. Hopefully, with more medical providers understanding the scope and benefits of doulas, a relationship can be developed with all involved so that everyone is working towards the same goals together, which is great birth outcomes. Next slide. And so how can we do better? And we've given some suggestions, and I'm sure that we're going to be working together to create more, but we just want to give you a few reminders. Q-tip, we always say this: quit taking it personally. Check your bias training and awareness. Apologize. It's okay to realize, apologize, and change. Like, you know what, I made some assumptions, and let's get back on track. I apologize, and I'm here to help you. Incorporate doulas. The statistical benefits of having doulas on the birth team are well known, and please use us. Train and educate more Black providers in reproductive health fields, including the field of lactation. Promote childhood education classes, and also hold each other accountable. How to deal with racism when you see it, how to address your colleagues, build relationships by doing community work. Healthy mothers, healthy babies, healthy families create healthy communities. Next slide. Now, this is an introduction to some of the support groups that we are going to be launching for our participants. We have, this is just like a general description of a few of them that we will have. So it's not limited to, but including self-empowerment, which includes self-advocacy, acknowledging your birth and postpartum, newborn care preferences. We have postpartum parenting, which is feeding your baby, breastfeeding and formula, talking about the benefits of doing that, at least 2 classes, and infant safety. Who is part of your dream team? Enlisting family and friends to help with pregnancy and postpartum. Building relationships and maintaining communication with your medical providers. Mental health care, how to recognize signs of PMAS, baby blues and beyond. There was another one about self-care. Now we're talking number 7, sex after baby. Are you ready? Safe birth spacing, birth control options, and information on STDs. The impact of trauma and violence on your pregnancy, how you can build resilience. We're going to have a dads and doulas dialogue, a class on grief and loss for families who have suffered pregnancy or infant loss. Fathers, partners, and grandparents, inviting the village. And then we're going to wrap it up with a graduation celebration. And as I mentioned previously, our Mocha Milkshake Cafe, which is a safe space to ask questions, meet other breastfeeding parents and families, discuss any concerns, challenges, and tips. This is a peer support group, but it is facilitated every Saturday, has been since last August, by Earth's Natural Touch. We have birth care, we have lactation counselors, doulas, perinatal health advocates, and Black breastfeeding professionals and affiliates on every Saturday morning, and they're more than welcome to join us during that session. The referral process, we've had the pleasure of meeting with Monica, and she will be a very key player. But we are relying on medical providers and other members of the team at Optimus to give patients that fit the criteria information about the doula program. So Monica Jackson, community health worker with the Women's Health Initiative at Optimus, will act as a liaison between Earth's Natural Touch, or ENT, administrators and the Optimus team. We're going to be providing posters and brochures that will be distributed to each site and used to introduce the program. And just a real short outline, we've worked out a process with Monica. She's going to be our primary contact for potential participants, and then she'll send us the information for the patients, and then the ENT admins will read the profile of each referral and then pair them with a virtual doula partner. And this is the criteria for choosing participants. It's patients primarily who are subscribed to Medicaid or are uninsured, and some may experience one or more of the following. And then we have our list. I mean, they could be someone that has HIV, AIDS, or other STIs, suffering from homelessness, smoking, alcohol abuse, illicit drug abuse, depression, other mental health problems, could be experiencing domestic violence or have experienced teen pregnancy, over the age of 35 and pregnant, group B strep, bacteria vaginosis, overweight, obesity, underweight, those experiencing hypertension, diabetes, asthma, periodontal infection, family history of breast cancer, previous fetal death, infant death, previous pregnancy, less than 18 months ago, history of complicated or high-risk pregnancies, or just not having any support person. And this is just some recommended reading that we suggest. It gives you a really good insight to everything that we've talked about today. And the next one, I believe, is just how you can get in touch with us. You can find us on Facebook. You can find us on Instagram. You can email us. You can email specifically at Mocha Milkshake Cafe. You can follow our hashtags. There they are, Earth's Natural Touch, Dajazuri, which describes our group, our sisterhood group, Natural Touch Doulas, or ENT doula class. And there we are at our last graduation. And I think that's it.
Beautiful presentation. Thank you, ladies, so much.
Thank you.
Thank you.
I had a question about the support groups, which are amazing, by the way, but I wanted to know if you could tell me a little bit about how often you'd be meeting, and if it would be just the Emmy participants, or would it be women from outside of the program too?
Yep. So we're going to start off with the first 15 families through the March of Dimes grant. And initially, when we planned for that, we were going to do in-person everything. But now that everything is virtual, we figured that we wouldn't necessarily have to limit it to those families. We can open it up to anybody at Optimus, and even wider if we chose to. And when we move into the Emmy program, we don't have to limit it to Emmy participants. It can be open because they're virtual support groups, so anybody can really log on.
And will they build upon themselves, or would, let's say, one session have, one of the topics that were listed, or is each topic like its own support group that has
Yep.
many sessions?
So we were hoping to do them maybe twice a month initially because we have to hurry up and get this grant done, completed. But when we move into the Emmy program, we can kind of space them out, spread them out. We're hoping that families will come from the very beginning and work their way through until the end. In that case, they would kind of build upon each other. But if somebody just popped in one time, they won't feel left out either. They'll be able to just jump right in and get the benefit of that specific topic as well. So it's not like they have to be there for each one. They can kind of pop in and out as they need to.
That's wonderful.
Yeah.
And also, the same thing, my question, because support groups are so important.
They are.
It's a great way for all of them to come together too and share experiences, not just, with their pregnancies, but also their experiences with their doulas. They're all going through the same thing at that time. So
Yeah.
the Mocha Milkshake, like the breastfeeding support group, is that open for anybody?
It is open. Anybody who identifies as Mocha is welcome to come. And the reason why we do that is because we want to make sure that we have a safe space for those of us who haven't had the support historically with breastfeeding. And sometimes we talk about our experiences with being Mocha, and how that not only impacts our experiences breastfeeding, but also with parenting and just living our lives in general. And we kind of need the support from the other people on the call to validate that and to be able to understand that and to relate to it, to make it relatable. And because you want it to be real, because this is your experience, right? So you want it to be recognized as being real. So the people around you who are also experiencing those things make it real for you, because you're like, okay, it's not just me. I'm not crazy. This is actually really happening because other people who look like you are also experiencing these things. So we definitely want to make sure that the people involved are Mocha, and can relate to the support that's needed.
Wonderful. Can you send us the link for that?
Yep. Mm-hmm.
Please?
Yes,
Thank you.
absolutely. Yeah, we can. Now, we also, throughout the other support groups that we also have breastfeeding built into that. And that is open to anybody. That is open to anybody who's coming through Optimus, or even further if we choose to expand it. So we don't have to limit that one to any particular demographic of people. We want to make sure that everybody gets the support that they need. But the Mocha Milkshake Cafe is specifically for Mocha, just because we have unique circumstances that need special attention.
Understandable.
Yeah. And then when we get those going, we'll definitely share the links for all of those as well. And now, because we're kind of on a tight time frame, we'll probably be doing support groups twice a month, I think we said, in order to make sure that we can fit them all in.
No problem.
Yep.
I'm sure our women would really appreciate that.
Yeah, we're excited. We're
No,
hoping that they come.
No, we are super excited. This is such a treat. And it's such a privilege for us to be able to offer your services to our women. So thank you so much.
Amazing.
Thank you.
Thank you. This is Allison. I just want to thank everybody on the call, and thank you, Sayana and Cynthia from Earth High from Earth. That's such was an amazing presentation. Thank you, Dr. Gray and everybody at Optimus for this wonderful partnership. Really excited about it. So just want to put out my appreciation on National Women's Day today for all of you.
Yes, you. Allison. Thank you for being the woman that you are.
Yes.
Anybody else have any other questions?
Sorry, that's my baby in the background.
Hey, baby. I thought somebody was saying, yep, we got a question.
Leo.
Monica, Samara, no questions? All right.
No, I'm all set.
All right.
And the link, I know there's many providers that really wanted to be here today that couldn't. So will you send me the link so then I can disperse?
Yep. So we have recorded it and we have to wait for Zoom to upload it to their cloud. And as soon as we can get it over to you, you'll have the link and you'll be able to access it and share it with the other providers.
Wonderful. Thank you so much.
Yep.
Diana, can you CC me on that? Because I would love
Absolutely.
to have I'm gonna have my whole staff watch this just
Yes.
Oh,
to.
great.
Thank you.
Oh, the other thing, we kind of touched on it, but we didn't go far. The toolkit. We are preparing the medical toolkit for you all. So you'll have like almost like a supplement to what we just kind of went through, but it'll go a little bit further because there was so much that we wanted to touch on that we weren't even able to put into this 1 hour presentation. So we're gonna put them all into the toolkit so that you can have more information.
Oh, that's wonderful. Thank you.
Yeah. All right. I think that's it, everybody. Thank you for coming. It was good to see you all.
Thank you, ladies, so much.
And we look forward to talking to you again soon.
Thank you.
You. Have a good
This was
afternoon.
amazing.
Take care.
Bye, everybody.
Bye. Everybody gone? Let me stop recording. Okay.